Hello and welcome everyone to yet another session of Brandos. For those who are new to this program, Brandos is the breast and
Recording
endocrine.
in progress.
For those who are new to this program, Brandos is the Breast and Endocrine Society of Western Uttar Pradesh, where all the clinicians or specialists with an special interest in breast and endocrinology join together online on the last Friday of every month at 7 p.m. and discuss about breast and endocrine related problems. Friends, it is a problem-based learning program, a very unique program in its all sense, because in this program, we simply take a clinical problem very pertinent to our clinical practice, which we see in our day-to-day practice. I request everyone to please mute their mics so that we have an uninterrupted, hassle-free program. Less noise, more learning. Thank you very much. Okay, so this is a very unique program in its own sense, because it's a problem-based learning program. We pick a clinical problem which is very pertinent in our day-to-day practice. We discuss about that case in detail with the help of radiologists, pathologists, nuclear medicine physicians, or any other specialist who has ever involved in the management of that case, with actual images which are being described by the specialist in their own words, in their own version, so that everyone who attend the program, they develop a holistic sense in their mind regarding the management of that case, if that case comes to them in future. So they know how the radiology looks like, the report that we see, how those images looks in the images actually. They know what the pathologist report, how those photomicrographs looks actually. So we develop a sense in our mind regarding the reports. Not only that, radiologists, pathologists, they also get to learn how the reporting have an impact on the clinical management and ultimate outcome of the patient. Fine. Friends, since it's a breast and endocrine program, I'm a breast and endocrine surgeon. So we have the breast meets on every even month and endocrine meets on every odd month. Now, friends, April being an even month, we have a breast meet planned today. And this time we have a very interesting clinical problem. We all are breast surgeons. We all deal with breast cancer. But we all face the same clinical situation, that is upper limb lymphedema following axillary lymphadenectomy. It's a very common and very problematic clinical situation which has a huge impact, not only as a physical, aesthetic, but also psychological impact on the patient suffering with this problem. The arms become very heavy. The aesthetic look, it compromises, and it all have an effect on the quality of life of the patient. With advancements, more and more now we are shifting towards conservative management, not only for the breast lump, but also for the axilla. We are now more and more shifting towards sentinel lymph node biopsy. But not all the patients are right candidate for sentinel lymph node biopsies. They require axillary lymph node dissection. Similarly, this sentinel lymph node biopsy is not available, or not all surgeons are expert in doing sentinel lymph node biopsy and leaving axilla, not doing axillary lymph node dissection. So it is not possible every time. So we are faced with this clinical situation where we are supposed to do the axillary lymph node dissection, and patients are then more prone to develop lymphedema. What next? What can we do now? Till now, we have only conservative managements available in the form of like arm elevation, some physiotherapy, compression bandages and all. But are they sufficient for chronic lymphedema? Like, is there any other option available to us? So friends, in today's program, with the help of the experts, we will try to understand what are the various other treatment options available to manage those patients. Are those options readily available? Can we also, through some efforts, possibly provide those treatment options to our patients in our setups? Many other important things, including the pathophysiology, the grading system, we will try to understand in today's program. Now, friends, without taking much time, I would like to introduce our moderator. He's a very renowned plastic surgeon of Meerut, and I'm thankful to him that he took out his precious time to attend the meeting and accepted my invitation to moderate the session. Dr. Sandeep Kansal. Dr. Sandeep Kansal is a renowned plastic surgeon of Meerut. He did his graduation from Jhansi Medical College, MLB Jhansi Medical College, and later on he did his MCH MS from Jaipur, SMS Jaipur. Currently, he is a consultant plastic surgeon in various renowned hospitals of Meerut. Thank you very much, Dr. Sandeep Kansal, sir, for joining us today. And now I hand over the stage to you.
Thank you, Dr. Sudhi. First, I would like to congratulate you for starting such a great initiative of discussing very important clinical topics. Now, I would like to introduce Dr. Anshuman Manasvi. He is a renowned aesthetic and plastic surgeon and lymphedema surgeon. मेरी आवाज आ रही है सबको?
बिल्कुल बिल्कुल अच्छे से आ रही है.
I think can we mute everybody from the admin side?
Sir, you are the admin, sir. Then.
So is there an option of mute everybody?
We can request.
Mute all. Okay.
बस इधर joint थे जैसे.
Yes. Yes, please continue. You can unmute Dr. Sandeep and then.
Okay, sir. Yes. On behalf of Brendos Society, I welcome Dr. Anshuman Manasvi, who is a renowned aesthetic and plastic and lymphedema surgeon. He has done MBBS, MS, DNB, and MCH in plastic surgery. He is presently affiliated with Nanavati Max Super Specialty Hospital, Mumbai, La Transformation Plastic Surgery Center, Mumbai, and Bombay Hospital, Mumbai. Dr. Anshuman is a well-known plastic and cosmetic surgeon in Mumbai and India. He has experience of more than 20 years in the field. He earned his MBBS in 1994 from the prestigious medical college Jipmar, Pondicherry. His MS in general surgery in 1997 from Lokmanya Tilak Municipal Medical College, Sion, and his MCH in plastic surgery in 2002 from King Edward Memorial Hospital and St. GS Medical College. He is one of the few renowned surgeons in the world doing advanced lymphedema surgeries like lymphovenous bypass, vascular lymph node transfers, and other surgeries for lymphedema. He is also a breast surgeon and reviewer of Breast Disease Journal. He has many publications and talks to his credit. Now, over to the Dr. Anshuman for his talk.
Thank you, Dr. Kansal and Dr. Sudhi for inviting me. And I take this opportunity to impart whatever little knowledge I have to all the esteemed colleagues of mine. And I hope after this whole discussion, we all will be more intelligent and learned to manage the lymphedema in the more contemporary ways than what we have been doing so far. So it may be a 180-degree change from what we have been doing till now. But the changes in the lymphedema management, whether it is upper limb or lower limb, has drastically changed over last 7 to 10 years' time. And it's time for us to catch up. We are doing our bit. I hope more and more people are aware of it so that at least we are able to prevent lymphedema from coming to an advanced case. And we should have a fair bit of idea who is going to progress, who is not going to progress, whom we can reassure. Now we all know that there's a lot of digital way of monitoring patients. It is, in a way, it is easier also to keep a tab on patients. Not every time patient need to come to us and all that. So digitally, if we know that these are the patients who are more prone, then we can keep a better watch and ask them for measurements and all that at repeated time, catch their infection and things like that, and advise them. With this limited background, let me start sharing my screen. So Am I audible?
Yes, sir, you are audible, sir.
Okay. So today's topic is basic and advanced management of post-axillary lymphedema, lymphadenectomy induced lymphedema. I am Dr. Anshuman Manasri and I am based out of Mumbai, and request you to please do not click photographs and print screen, because it may violate the rights of the patients. That's my sincere request. I mean, in this age, we don't want to face any medical legal problem. So today's discussion would be very at a informal level. If you have any doubts, you can ask me. We want to impart knowledge and we want to gain knowledge. It is a learning experience for me as well. So I would like to change the subject to what is the optimum evidence-based management of patient undergoing axillary lymphadenectomy in perspective of lymphedema. Okay, this is optimum because basic everybody has to do, and advanced some patients will require, some patients will not require. Secondly, the management, since everybody is a doctor, we see so many patients. Management essentially of upper limb lymphedema and lower limb lymphedema, both are same. So almost same. So one must keep in mind, especially in our country where filariasis is very common, uh, make sure that this knowledge can help you get them proper treatment. So first of all, not all patients lymphedema, and not all patients who develop lymphedema progress to advanced lymphedema. Now, as Dr. Sudhi was telling, that we have now minimally invasive or minimally aggressive lymph node dissection, sentinel lymph node dissection, level 1 and level 2 lymph node dissection and things like that. So not all patients will develop lymphedema. And even for when we are clearing level 1 and 2 and 3, the techniques have been modified in such a way that more and more lymphatics are preserved. The incidence of upper limb lymphedema has drastically come down in what we have seen over last 7 to 10 years or maybe more than that. And the learning also with each other with the digital platforms is much more easy. So we are seeing less and less upper limb lymphedema, and that's a very good sign which is happening. And many times we are seeing the lymphedema which is occurring after the radiotherapy, especially when we are doing breast conservation therapy, and the radiotherapy machines differ from place to place, the planning differs. So if the axilla is sort of radiated apart from the breast, and the planning is a little bit more not very accurate, you will have more lymphedema incidences after radiotherapy. And obviously, those who come in advanced cases, they will have when supraclavicular area and all are radiated. Then the lymphedema incidences on a rise. But it is important to say, identify that those patients who are not going to progress to advanced lymphedema. So what are the factors which are predisposing the patient? Number one, type of axillary clearance, post-op radiotherapy, type of radiotherapy. Even today in India, we have cobalt going on at many places. What is the disease, aggressive, or whether there is a lymphatic obstruction because of the disease itself. And what type of lymphatic structure does the patient have from birth? This is very important, because if we understand the lymphatic physiology, which I will tell you, lymphatic anatomy, this is your savior. Okay? And post-op lymphatic protocol, whether it is followed or not. So these two things are there in your hand, which a lot of things now, I know the first priority has to be to clear the cancer as much as we can. Whether if the facility is not available, and in the hope that we have to clear everything, if we are clearing level 1, 2, and 3 lymph node. It also may be justified in a place where nothing else is available to know whether how aggressive is the disease and all that. So if we are seeing a patient which is like this, and we don't want to see it, we must have a proactive approach. And this is what will help us in preventing it from coming like this. And yes, I'm glad to share that it is possible today. Now, some basic facts about lymphedema anatomy, which is very important, is that lymph consists of channels which have muscular walls. And these muscular walls contract in a peristaltic way to propagate the lymph. And it consists of intima, media, and adventitia. And there are various valves in it, and which are present intermittently. In between, it is called lymphangioles. And they are arranged in superficial and deep layer. But more important is this diagram, which is there. There is a peristaltic movement. And this, the layer which is there, the muscular layer. Now, if you go back to the physiology, you will know that the more the muscle stretches, lower its ability to generate more pressure. Okay. So if a lymphatic is obstructed, two things happen. One is that with the dilatation, the valves become separate and they become ineffective and incontinent. The second thing is even the peristaltic movement becomes less and less effective. So the bottom line of treatment is that we should prevent the dilatation of the lymphatics. Okay, please keep this in mind, because this is something which is going to be there in your mind to be able to optimally manage lymphedema. Now, types of lymphatic drainage which is there from the congenital point of view is that if you see there are two trunks in the middle diagram. I'm just trying to enlarge it. If everybody is seeing, there is a diffuse lymphatic network which finally goes from the medial end and goes to the axilla. This is what we clear. There is another trunk which is there, which goes along the cephalic vein, and this is something which is not required to be cleared in axillary clearance. Okay, so this is one pattern of lymphoscintigraphy where you can see there's only axillary lymph node which is there. And this is another patient in which you can see this is the hand and this is the axilla. You can see there's additional cephalic node which is also there. Now, this is a patient's post-CA breast operated patient's lymphoscintigraphy, which shows additional lymphatic trunk. And this patient, we advised only conservative management, and she has benefited tremendously, and she does not require anything else except for conservative management. So this patient is not likely to progress further. Now, this is again, I'm emphasizing a stitch in time saves 9. So imagine there is a first presentation when the patient comes. There is an incomplete lymphatic obstruction. Now here, there has to be an intervention to prevent it from becoming a complete obstruction. How will this become complete? It will become complete if there is an infection associated with fibrosis. So one important message which should go is that any patient who has undergone a breast cancer surgery, should be advised to prevent infection. In case there is minor cut, we should be able to see the patient as early as possible and start on antibiotics. broad spectrum antibiotics. We should not allow it to neglect. Please make sure a wrong message is going when people say that don't do this, don't do that. So they become afraid even of a surgery. That you are telling that me not to wear anything, not to touch, go near the gas, not to prevent it from getting burnt and all that. But what is the logic of it? So just 1 minute extra of putting that if you get hurt, see your doctor. If you get cut, see your doctor. And take advice will go a long way in creating that misconception that nothing surgically should be done on the other hand. If it is required, and I'll tell you why, because in all our series, not even a single patient had a problem, major problem, even after these lymphatic surgeries of major infection. So we are busting some myths as well. Okay, coming back. So if there's an incomplete obstruction, we have to prevent it from becoming a complete obstruction. And if the complete obstruction is there, which we will know only on a lymphoscintigraphy, then we have to make sure that we intervene early, surgically, so as to prevent it from getting dilated. If it becomes dilated, it will have, the valves will become incompetent, the peristaltic movement will be hampered, and then failed propagation. Again, more infection, more stasis, and more infection, and that will further lead to more fibrosis. So one important message is we should not allow incomplete to become complete. And if it is complete, then we should surgically intervene early. Now, so if we need to have a control of lymphedema, a strict and standard post-operative lymphedema preventive protocol is required. That is, it should be evidence-based. We are all going for evidence-based medicine as far as possible. Sometimes it may not be possible, but if it is possible, why not? So our protocol is subject the patient to lymphoscintigraphy after 4 weeks of surgery or completion of the radiotherapy, everything when the treatment is complete, and see whether the patient has additional trunk, whether the main trunk is fully obstructed or it is partial obstruction, which is very classical on lymphoscintigraphy. And then you know which patient to take more precaution, which not to, kisko mana karna hai, ki bhai you don't, you be very aggressive in managing your cuts and infection and all that. Some people whom you can be casual, no, a lot of lymphatics are there, you should not be bothered. So it gives you a great insight into how you should be managing your patient post-operative. To check if the lymphatic peristalsis is preserved, it can be done through ICG or gamma probe if it is possible, yes. But if lymphoscintigraphy, which is a relatively cheaper mode of investigation, if it is there, which shows that there is a good flow in the lymphatics, there's no need for all this costlier investigation. Lymphoscintigraphy is the basic investigation which can guide you further. Second thing is, in case you find that there is some obstruction, some incomplete obstruction, many point measurement in respect to the bony points at fixed points should be taught to the patient, and single person should be measuring and should be giving you the data, and documentation by photograph. Limb circumference measurement is equally important rather than plethysmography and volume displacement technique and all that, which are cumbersome and hardly anybody follows it except for the research purpose. So coming to the most important thing which all of us should have is the non-surgical conservative management. Now, it requires, you cannot, as a surgeon, you have your measurement part to your nurse or physiotherapist with inputs from a plastic surgeon. Regular limb measurement and graph charting, as I told. Now, 3-4 points which are important. One is compression stockings. All patients must have. Now, one important thing is the compliance or 4-layer bandaging. I think everybody knows what is 4-layer bandaging. It gives more compression and multi-layered is there. Initially, there is a stockinette, then there is a foam, then there is a short stretch bandage, then there is another layer of bandage. Now, crepe bandage does not give enough pressure. So, crepe bandage should be substituted by short stretch bandage. Okay. One problem about is of the compliance. So especially those who have partial obstructions. Even if you are not able to even if they are not able to tolerate class 3 pressure garments or stockings, even class 2 is better than not having anything. So check on that. The limb elevation during the day, sometimes change of lifestyle, manual lymphatic drainage. If our nurse can train them how to do, in couple of sessions, they will know how to do it at their home. There is no need to involve physiotherapy and increase their cost burden because it has to be done every day. So half an hour of every day of manual lymphatic drainage, which is a 4-stepped pattern of massage, starting from initial proximal to distal milking and then from distal to proximal milking of the lymphatics is there. If lymphedema pumps are available, then please make sure that their pressures are set by somebody who knows it, and the pressure should be between 60 to 70 in non-lymphedematous, not lymph, 60 to 70 or 80, not more than that. And suppose something has become lymphedematous, then it should go on to 100, 120. Sometimes if it is thick skin, we give up to 180 as well, which is the optimum. Okay. Am I audible?
Yes, sir.
1 minute. There is some internet. There's a net issue. Give me 1 minute.
No issues. I think, sir, your voice is now very clear.
Okay, okay. It's clear. Just I'm changing the. Is it okay?
Yes, sir.
Is it okay? Okay.
Yes, sir. So we can go ahead.
Okay. Thank you. So lymphatic pumps again, and what is the point where you know that this is a good pressure is that when the patients will complain earlier, a thick skin will complain later. As simple as that. And teach all patients manual lymphatic drainage, even if they have a lymphedema pumps, because sometimes they can become erratic. Then the third thing, important thing is skin care and hygiene, web space infection and hygiene, fungal infection and all that. So these are very, very important. And earliest treatment of any infective focus. Now, coming to the surgical management. So these things of non-surgical management, everyone should be doing, and physiotherapy as well. If they know there's no need for actual physiotherapy, but if they know that they have to do some exercises which can pump the lymphatics. Okay. Coming to the surgical treatment, best to be done before the valves are damaged. types of surgery depends on the stage the patient comes, and the surgical protocols are still evolving. We have made a lot of progress, but there's a lot more to be done. Three important surgeries which are done. One is lymphovenous bypass. One is where we join the lymphatics with the venules, not with the big veins as it is shown over here, but with the venules. Okay. Venules have to match the lymphatic caliber for it to be effective. Otherwise, there will be a back pressure which will result in a bypass or a shunt which is not effective. This is a highly challenging surgery, but rewards are great. The second is vascularized lymph node transfer. Now, first surgery of lymphovenous bypass will give you instant result. Okay, within 2 days, you will find that the lymph has come down significantly. I'll show you some results. Next is vascularized lymph node transfer, and what it means that you take lymph node group from some other place, and like other supraclavicular area or inguinal area, which is not very preferred, or submental area, or from some other area, omentum and all that, and which can be transferred to the axilla using a microvascular free flap technique. And how it works? It works by generating new lymphatics. Mind you, there are no lymphatico-venous anastomosis for afferent and efferent lymphatics done. Now we are transferring the lymph node group along with its vascular pedicle, but that group will have efferent and afferent. Now, but we are not joining efferent to the arm lymphatics and efferent to the proximal lymphatics. We are not joining. So it happens by the release of growth factors, which help over a period of time lymphangiogenesis. That is the most accepted theory. We still do not know how it works, but it does work. And in many patients, it does work. Okay. Then is vascularized lymphatic transfer, which means instead of lymph node, we are taking the lymphatics from the skin and transferring them based on the vascular pedicle. This thing is a liposuction, which can be done in a few patients, and if done well and preserving the lymphatics, the results can be great. There are some modifications which are there. Not enough studies on liposuction in lymphedema are there. But in early stages, soft lymphedema, liposuction is an option, especially if it is done on the sides where they are not much of lymphatics. But if they are lymphatics, and suppose on the medial side, and if we are doing it, then we are actually destroying the lymphatics, which means that the patient has to wear compression garment all throughout his life. So with a caveat that yes, it is effective, not enough studies are there to give a green signal to liposuction indiscriminately, because it's an easy surgery, but you may land up in a problem. Then there's a reconstructive surgery like skin graft, flaps and all for wound coverage and all that. And debulking surgery. We do debulking surgery if there's a huge hanging skin, or after lymphatico-venous bypass where the limb has become soft and hanging. The skin is loose. Okay. So that is what. So here, this is a small video of how we can identify the lymphatics giving ICG. ICG is given in the first web space, and then we can mark it. You can see it getting marked in the pen. So it will keep showing till the axilla. It will keep showing green, and we can mark it on the upper limb where the lymphatic channels are. And those places we can do lymphatico-venous bypass. Okay, so this is how the marking is done. And we can keep going till the axilla and find out. But for lymphaticovenous anastomosis, actually doing one has to inject a blue dye. One has to inject a blue dye. So this is how it looks after it is mapped with sort of ICG. But there are some injections of the blue dye, isosulfan blue. Methylene blue is not that effective. Isosulfan blue is much more effective. We inject, then it goes in the lymphatics, and then we can find the lymphatics, then adjacent venules, and we can anastomosis. But there is a big if over here, and the big question mark, because in advanced lymphedema, this ICG lymphography is useful only with a depth of skin of less than 1 centimeter. If the skin becomes thickened, as in advanced lymphedema, we will not be able to use the ICG machine. So there, methylene blue or isosulfan blue may be effective or may not be effective because of the fibrosis. Okay, so clinical judgment and the learning curve becomes very important. For me, it took more than a year to actually be able to confidently say that this is a lymphatic, this is not something else, just a strand and things like that. So what is the grading, lymphedema grading? Now, traditionally, we have seen lymphedema grades, grade 1, 2, 3, 4, grade 4 with a lot of thick skin and all that. But yes, so classically, I would want to probably change that into early lymphedema and advanced lymphedema. Grade 3 and grade 4 are advanced lymphedema because just by the virtue that the skin is very thickened. But the latest lymphedema grading is by Cheng, who is there in Taiwan, is doing some really wonderful job. And this is something which we must pay a lot of attention to. Now, if there is what is the way to understand that there is a lymphedema? There is a circumference difference. You just take the other limb, see there is a circumference difference. If it is less than 10%, then it is grade 0 lymphedema. Okay. And also is important is that lymphoscintigraphy. That is what I was telling. After the radiotherapy is done, take your time for 3-4 weeks and then subject the patient to a lymphoscintigraphy. See whether there is a partial occlusion or total occlusion. Now, if the circumference is less than 10% and if there is a partial occlusion, then the lymphedema is reversible. Okay. And you can continue only with rehabilitation. Okay. And without any surgery. But if there is a partial occlusion, but the circumference has increased from 10 to 20%, in between 10 to 20%, that means the valves have already stretched and probably becoming ineffective. So this is a stage where there is a more dilatation of lymphatics. The propulsive force is less. The valves are becoming incompetent. So here, the choice of surgery comes into play. Now you see there's a very small window of less than 10% circumference difference. And this is where the prevention will make a difference. If you have to prevent, lymphedema from going to advanced lymphedema, here is the time where you have to really focus that patient should do non-surgical lymphatic management religiously. Even if we do not take this whole data with a lot of sanctity, I would still say that let's increase it to 10 to 15%, but more than 15% definitely will require surgery in terms of lymphovenous anastomosis. Otherwise, it will keep increasing, going from second to third, third to fourth. And any total occlusion will require a surgery in terms of lymphovenous anastomosis or vascularized lymph node transfer. So skin changes are seen in very severe, which is stage 3 and 4. But important to re-emphasize is that early stage lymphedema is where only one can get a reversal by non-surgical means. So let us be very, very focused on creating a separate protocol for lymphedema by all of us, so that patients don't go on to the next stage, especially those in whom there is a partial occlusion, which you were talking about, sentinel lymph node biopsy, minimally invasive surgery, level 1 and level 2. So these are where the partial occlusion you will get most of the times. But we do not want them to progress to total occlusion because of infection and stagnation and all that. So lymphoscintigraphy remains the single most important investigation on which the treatment protocol can be formulated. Please do not rely on clinical judgment. This is a 180-degree turn. Okay. Now, based on my experience of about 100 patients overall, both upper limb and lower limb included, I have little reservation about vascularized lymph node transfer. Rest everything I agree. But vascularized lymph node transfer in my protocol comes as a second line of treatment, and I will tell you why. But yes, there are people who can justify the use of vascularized lymph node transfer in lymphatic surgery. Just to show, this is how the lymphaticovenous anastomosis looks like. The diameter would be somewhere around half a millimeter or less, even less than that, of the lymphatics and the venules of when we are doing. Maximum effective would be around 1 centimeter. More than that, it is not effective as well. Okay. There's a small video. We use 10O or 11O sutures for this kind of a surgery. On an average, in advanced cases, which we get more often, the surgical time is somewhere around 8 to 10 hours. 4 hours is my average time to dissect the lymphatics and the venules, because there are a lot of fibrosis. So if we are able to, but compared to that, if the patient comes early, we would probably be able to finish the surgery in 3 hours time, or 2 hours time, or 2.5 hours time. So that is the difference in the magnitude which happens because of the.
Sir, can you please explain, you are joining what part of the lymphatics with the what part of the vein? Which vein is?
You can make out even that the lymphatics are flowing in the veins. Now, this is vascularized lymph node transfer. We take from supraclavicular lymph node. We have opposite side, and this is with the pedicle. We have done a free flap, and this is how is the closure. Relatively simpler surgery, and but the results, especially in advanced cases, are not so great, because there is a compartmentalization of upper limb in advanced cases. So there are various places of obstruction. I will tell you in my next slide. Some interesting findings would be this mega lymphatics, which are useless because if we anastomose with this kind of a vein, this big, there will always be a reflux. So it can be done with the end to side, usually not very effective. You immediately get green urine of isosulfan blue after a couple of hours, even though you may not have picked up during the dissection, because sometimes because of fibrosis, but there is a delayed flow of the blue dye, and sometimes we have to resort to abdominal binder and all for advanced cases. So this is where lymphatico-venous anastomosis has been done. And there is a vascularized lymph node transfer also, which has been done. This is the vascularized lymph node transfer. So these are the kind of results which we can expect. Okay. These are around 3 to 4 months result. Very easy, has long-lasting results are there. Okay. So this, you can get some good results even with non-surgical management as well. Okay. And this is a debulking surgery, which can happen primarily. Now, remember, this is your line of axilla. If you have to take it out, okay, then you have to make sure that the lower part is taken out more than the upper part, so that you damage least of the lymphatics. And I'll show you how. This is a lower limb patient, but I'll show you how immediately on table, within 2 hours of surgery, you get the blood. So this is the kind of reward you feel. And initially, I had a lot of anxiety whether I'll be able to find the lymphatics or not, because sometimes the blue dye does not take. But with experience of more than a year or two of continuously doing, we are now able to find, even if there is no blue dye which takes up, we are able to comfortably identify the lymphatics. So we did a study of 22 patients with grade 3 and grade 4 lymphedema, treated over 5 years. And the results are, we saw what is the number, how was the fibrosis. This is for advanced, number of anastomosis done, incidences of lymphangitis and all that. So protocol, I'll skip isosulfan blue. So important is to realize that all patients improved. Okay. Relapse rate was 14%. Intraoperative fibrosis was 100%. 2 patients required repeat LVS, and which improved. So 100% long-term improvement in the relapsed patient. No patient had lymphoria after the surgery, which is the biggest fear in our mind. And the incidence of lymphangitis came down to 4.5%. So it is very, very important to understand that we should not be fearing such surgeries. And my conclusion is that multiple lymphatico-venous bypass helps. More than 70% of our patients in our series improved with very good result. 25% of the patients had more than 70% decrease in their circumference, but average reduction was around, in advanced cases, around 54%. Relapses do very well after repeat surgery. Coming to the advanced cases, as I told you, there are multiple compartmentalization which occurs. So one vascularized lymph node transfer will regenerate the lymphatic over here, but that can drain only over here. It cannot drain over here or over here because of mechanical obstruction of fibrosis and things like that at multiple places. This is where I do not agree with many of the surgeons that lymphatico-venous. 2 of our patients who relapsed were of this kind. and who improved over here but relapsed lower down. Okay, so multiple lymphaticovenous shunt is the answer in my mind. Now, challenges is intraoperative fibrosis, lack of optimal size of venule with valves less than 1 millimeter to 1.5 millimeter, matching the lymphatics, erratic blue dye uptake, unpredictability before the surgery. So, what is the simplified algorithm after the breast cancer surgery? Number one is to prevent cancer is the first goal. Do optimum surgery. Don't bother about lymphedema. Second is have a separate team of lymphedema. Okay. Have a written protocol for patients to follow, give you measurements and all that, send you at repeated time. Start the protocol immediately after surgery. Can stop in between, or I mean, if there is a need, but usually there is no need even during the radiotherapy. Do lymphoscintigraphy 2 to 4 weeks after the surgery. Okay. And then check and proceed as it has been discussed. Can lymphatic surgery harm a patient? Usually no. The surgery does not touch any normal lymphatics the way we do it now. And it is done very high end magnification, more than 10x. And it is possible to identify normal draining lymphatics with preoperative lymphoscintigraphy and intraoperative ICG or gamma probe. The preserved lymphatics can be easily identified, and there is hardly any chance of infection, increase of infection or lymphoria after the surgery. And there's a very high probability that the patient will improve after the surgery. So go for it. The future of lymphatic surgery is during the breast cancer surgery, if we are able to do lymphaticovenous shunt. Now, if we have to do this, there are some thoughts. Some centers have started doing it. This is in the initial stage. We still do not know who will develop lymphedema, who will not develop lymphedema. But if somebody wants to do it, my suggestion would be then do a preoperative lymphoscintigraphy before the breast surgery. See whether the patient has a lymphatic trunk or cephalic trunk or not. If the cephalic trunk is present, then definitely that patient is not a candidate for prophylactic lymphatic surgery. Then you decide based on what type of clearance you have done. If you have done advanced clearance level 1, 2, 3 for advanced disease, you may be justified in doing it. Otherwise, it may become an overkill. It may, because not all patients, especially with sentinel lymph node biopsy and all, will develop this lymphedema. So best way is that why to make the patient undergo supramajor surgery, additionally adding 2 hours of surgery, more cost and all that. Better to do a lymphoscintigraphy after 4 weeks of the treatment is confirmed. Thank you. Thank you so much. This is my team. We have 2 plastic surgeons along with me, and the whole lymphedema team is there. Thank you so much. Any questions, any discussion, I am open to. Thank you so much.
Thank you very much, sir. That was a very elaborate and very eye-opening presentation that you delivered today. Many new things I learned as a breast surgeon, which were really new to me. And so there are a lot of questions that popped up, not only in my mind, but in many of our participants also. They want to understand. So I am taking one by one. So if possible, there may be some very petty questions which you may feel.
No problem.
But anyhow, we are open to discussion for every, so that we learn a lot from you. So you mentioned about the post-operative lymphatic protocol. So I think that is the conservative management you were talking about, limb elevation and other things. That too. Fine, sir. Okay. So indication of surgery you mentioned. Sir, my question is, like I start with the now. If you can allow me to become a host, I now share one case to you. So for the sake of our audience, if you can now tell what is the staging or grading for you about this patient and how would you like to manage this case, okay? And then I will ask you some other questions. So can you please make me host, sir?
How to do that?
So you go to participants, select my name and make me host.
Your name is Pratyush.
Make a host. Yes.
Pratyush. Your name is Pratyush.
You are the host now.
Fine, sir. Thank you very much. Sir, my name is Pratyush, sir. Pratyush. You make Pratyush as host.
Let me.
Pratyush, sure.
Yes, you are host.
Fine. Okay.
You are the host now? Okay.
Yes, sir. Yes, sir. Okay. So, sir, she was a 35-year-old multiparous lady who presented with a T2N1 lesion in her left breast, and she consented for MRM. We did a complete surgery with axillary lymph node dissection in her case. We don't have a facility of sentinel lymph node biopsy as of now, so we did a complete axillary clearance since she had suspected lymph node metastasis as well. So following surgery, she had chemotherapy and radiotherapy. But after radiotherapy, she developed lymphedema in her left upper limb. So when she presented to us following radiation therapy, she had takriban of almost 20 to 30% difference in the circumference compared to her uninvolved limb, and the skin was non-pinchable. So stemmer sign was positive in her case. So we started her on the usual lymphatic management, lymphedema management protocol. Now, sir, please suggest. Now, this case was operated in 2018. So radiation therapy was finished in January 2019. It is already 3 to 4 years. So what would you suggest in her case? Like, should we continue doing physiotherapy and other conservative management? Or is there any scope of surgery in her case as of now?
So first thing, allow me the liberty to tell that Stimmer's sign and all that is obsolete. Don't rely on your clinical judgment. This is my humble request. Evidence-based is circumference, which you have taken, looks like around 20 to 30% more than the other side. Now, do a lymphoscintigraphy, which is a basic investigation. And if you are able to find lymphatic drainage across, either through the axillary side or through the cephalic side, then in that case, you can continue with the conservative measurement. But if not, this patient needs a surgery. Otherwise, sooner or later, this patient will land up with more advanced lymphedema and more problematic. So lymphoscintigraphy is one which is going to actually help this patient in formulating the plan. And in the meantime, at no point before or after the surgery, if at all she undergoes a lymphatic surgery, the non-surgical treatment should stop. That is one point maybe I forgot to mention, that even after the surgery, the lymphatic management protocol of limb elevation and a pressure garment should continue lifelong, because unless and until it is less than 10% increase, the valves are already damaged. If the valves are damaged, propulsion will not happen as easily. We have to have mechanical force to propagate that lymphatic. So physiotherapy, pressure garment, and manual lymphatic drainage or lymphatic pump have to be there lifelong.
So basically, the thing is, in such case, in chronic patients with long-standing lymphedema, it is assumed that like the valves are already damaged, the propulsion is already hampered. So we need to provide a consistent propulsion in her case. But these surgeries, they help in providing alternative pathways, because those pathways are either blocked or they are chopped off during the surgery. So these surgeries help to provide smooth alternative pathways for the drainage.
And, and also important is that, see, whenever we are doing a alternate bypass, we are putting it to there is a high pressure which is already there. So fluid will pass from the lymphatic to the vein. But gradually when the swelling comes down and down and down, then the pressure will start equalizing. Okay. And then the pressure in the lymphatics will be less than that of the vein. Okay. So that is where the chances of lymphatic blockage is there. So that is where we need to be very careful in telling, don't be very happy with the reduction, initial reduction. You continue with the stockings and massage. Stockings faster is the most important thing to have a long-term result without relapse.
Fine, sir. Thank you very much, because that was my next question. What is the percentage reduction in the circumference of the limb? Like, should we expect the complete normalization of the limb, or there will still be some amount of residual lymphedema?
Yes, there will be. See, it all depends what are the pathological changes that have already happened. Now, lymphedema leads to more adipose tissue. More adipose tissue give rise to more lymphatic fluid production. So it's a vicious cycle. Anything which has increased fibrosis, skin thickness, and all that is not going to reverse too much. Only the fluid is going to get drained. So in advanced lymphedema, we can expect 50 to 60% reduction. Some patients may go on to 70%, as I told you in my series. But if it is caught early, then in that case, we can expect around 90% to 100%.
Then, sir, thank you very much. I got your point. The important thing is whenever it depends on the time of surgery. So what this surgery do? They reduce the displaceable fluid. Jitna bhi display. If it is chronic, it is fibrosed, or agar kuch chronic changes aa gaye, that thing will not reduce. That will remain. Only the displaceable fluid, a certain amount of displaceable fluid will be, and the important thing is it will not progress further, at least agar uska due care kiya, because like if we don't do this surgery, uske baad bhi hum compression or baki conservative management karenge, there will always be chance that it will go on increasing. Now following surgery, we provide alternative path. So then तब हम जब कंजर्वेटिव सर्जरी कंजर्वेटिव मैनेजमेंट करेंगे, एटलीस्ट फ्लूइड को आगे जाने के लिए रास्ता है. बाकी उसने जितना डैमेज कर दिया, जितना परमानेंट चेंज कर दिया, वो तो वापस नहीं आएगा, लेकिन कोई नए चेंजेस बनने के चांसेस कम हो जाएंगे. So is that am I right, sir?
You are 100% right, and you used a very good word called displaceable fluid. So another important thing is the cause of increase in lymphedema. Okay, even if there is a partial obstruction of lymphatic. Suppose you have done lymphatic minimally lymphatic dissection and things like that, and there is some flow which is maintained, which is, let's say, 20% of that of normal. Now lymph is flowing through that at a lesser pace, but still flowing. But in case there is an infection, one episode of infection or lymphangitis can bring down from 22, it can bring down to 5%. That is where it increases. So incidence of lymphangitis prevention, incidence of lymphangitis becomes much, much less after these surgeries. Otherwise, lymphangitis is the biggest culprit. Otherwise, the patient having sentinel lymph node biopsy done, why should he or she develop lymphedema? It is the lymphangitis which is the culprit.
Yes, sir. Thank you. And sir, the important, now we know who are the eligible patients. Almost all the patients are eligible. The success rate will depend upon how early they have presented, how much is the displaceable fluid, how much lymphatics are spared and all. Sir, can you please elaborate if any specific contraindication you would like to share with our participants? any patient you would not like to do, or in all patient we can do anytime, anywhere we can consider?
Only so, okay. I have burnt my hands. So one should not be very enthusiastic in doing this surgery. Make sure that the patient will follow up with the non-surgical conservative management after the surgery. Let the patient earn the surgery. Okay. There have been breach of protocols because of which relapses have happened. So there is improvement. Okay, 4 months, 5 months, 6 months, then they stop doing that massage and all that. They start taking easy and it relapses because there's a lymphangitis episode, and maybe whatever we have done, that also may get blocked. Who knows? So it is important that we make sure that the compliance after the post-surgery will be there. At least we should be mentally assured in our mind. That is the only place where I would say that we should not try it, not go for it. Otherwise, it is all worth trying. And so far, I have not had a single patient who has not benefited for at least 5 to 6 months' time. Some patients have relapsed because of these things, and there may be other factors also, but they are long 4 years, 5 years, heavy limbs coming down. So obviously, lower limb is much more than upper limb because the surgery for cervical cancer and all that, or groin dissection, are all complete. We don't have sentinel lymph node biopsy over there. So they are generally complete obstruction and all that. So much more common cervix cancer undergoing Wertheim surgery, or ovarian cancer undergoing para-aortic lymphadenectomy and all that. So yes, lower limb incidence is much higher than the breast, but the treatment and overall view remains the same.
Thank you very much, sir. Sir, my another question is कि what is the failure rate? मतलब आपसे बात करके समझ में आ रहा है कि there is a 100% success rate, but is it really 100% or some amount? What specific consent would you like to take from the patient before undertaking the patient for the surgery?
Very nice. Even today, now I'm relatively relaxed after more than 100 surgeries that I will be able to identify the lymphatics, because many of the patients, at least in advanced cases, the blue dye, which is injected around 5 centimeters proximal, 5 to 10 centimeters proximal to the area where we are looking for lymphatic channels, they do not take up because of the fibrosis. They don't travel till that. And I don't sleep the night before such surgeries. The anxious moment that whether I'll be able to find or not. And I tell upfront to all patients that there is 5 to 10% chance that I will come out and tell you that the surgery has failed. This is specifically written in the consent that I may not be able to find the. Second important thing is finding the lymphatics. Now, after this long, I am able to say that finding the lymphatics is easy. Finding the same size vein is more difficult. You may get a bigger vein, which is of no use. You have to have a venule which is near that lymphatic, which you are going to join. So venules are the most critical factors as far as I am concerned for lymphatic surgery. And I tell all patients that I may come out and tell you that the surgery has failed.
Okay. So, sir, lymphatics, I understand you identify with ICG. So how do you identify the venue?
We don't identify with ICG. We identify with blue dye or clinically. ICG is only for external marking for very early cases. Most of our cases are not eligible for it. Venules, there is no way to identify. We can have that infrared lighting to see the veins and all that. But we have to go really slow to identify the veins. Really slow once we cut the dermis. So it takes a lot of time.
Okay. Sir, can you please tell, like, आपने time तो बताया. For now, after more than 100 surgeries, you take 3 to 4 hours. So
for advanced cases, I take around 7 to 8 hours.
7 to 8 hours.
That is the average time, for around 8 hours. 4 घंटे सर्च करने में लगते हैं appropriate lymphatics, vein and to dissect. और एक anastomosis में सब मिला जुला कर आप समझो तो around 1.5 hours, 1.5 hours.
It's a very tedious and a time-taking procedure.
Very tedious, very tedious. Early cases, yes, you can do it around 3 hours time.
Because a lot of dedication must be required, especially from surgeon side.
And everything is there in microscope. The whole back goes into a spasm. So, and let me be very honest. I mean, nobody's fault, but the awareness is not so much there that any surgeon is reluctant to tell his patient that, okay, there's a minor swelling, go for a surgery. Okay. So that mindset is still there, that clinically it is not much, so it will settle with pressure garment and things like that. But in fact, what I'm trying to say is that we have a window only of 10%, 10 to 15%, where things can be reversible. So there's a mindset, no discredit to anybody, but gradually the awareness will happen that lymphatic surgery, if we want the best results, have to be done early. And that is how it is happening in Taiwan, Korea, a couple of places in France.
So what is the approximate expenditure to the patient? अगर patient को suppose हम कहते हैं हमारे यहाँ भी कई patients हैं, हम उनको कहते हैं कि अच्छा यहाँ पे lymphatic surgery आप यहाँ, तो उनको कितना cost पड़ जाता होगा तकरीबन?
I mean, that is a big challenge because I am not able to do this in a mid-sized hospital because of the quality of the microscope. I started doing with my 6x loop, okay, which is almost as good as a small microscope. But my results, I've realized that when I did in the first time in the microscope, I realized that results are much more superior or will be much more superior. So I'm operating only in Pantoro microscope of Zeiss or some equivalent of that. That is available only in big hospitals. Big hospitals, the budget goes high. So in a general ward in Mumbai, around 3.5 lakhs approximately it will come. So that is one thing which I don't know how to address. Mid-sized hospitals are not ready to invest that much of money in a microscope. So this is a bit of a challenge. In big hospitals, surgeons don't get much, but the maximum pie goes to the hospital.
That's a problem because
that is the problem. But
it is a surgical domain. But
yes, but unfortunately, I don't have much options over here till the time some small hospitals are able to buy that kind of a microscope, which we are able to do. Otherwise, it's a very simple surgery from the point of view of invasiveness. Okay. So I mean, it's not something because for which the patient has to really has life at stake and things like that. It is just the technique that it takes time and microscope and all, which is more critical. So if a mid-sized hospital wants to buy it, the cost will come down.
Yes, certainly I can understand, and I really appreciate doing 8-hour surgery. मतलब पूरा दिन ही एक तरह से सर्जन का लग गया, तो उसको they really deserve a good outcome from this. But cost is always a major factor in India.
Yes,
cost is always a major factor. So many aspiring surgeons, enthusiastic, motivated surgeons, they are not able to perform and show their capability because of cost factor, especially in private setting.
No, yes, 100% agree, 100% agree. What to do? I mean, this is something which needs a system change, and we don't have answers.
Certainly, sir. Yeah, sir. इसमें just want to understand कि जो अगर skin changes आ जाते हैं उसके ऊपर काफी keratinization हो जाता है या कुछ. So when we perform these surgeries, so are these skin changes also reversible or what?
So some of them do reverse.
Okay.
Some of them do reverse. And skin changes will happen only when the limb has become really big and all that. Some of them will reverse, and then they will become loose or low, and then you can remove that with excision surgeries after that. And these patients do improve. I have patients who have improved more than 60-70%, still improving. It takes time, still improving. So it's a very rewarding surgery, as I would say. I mean, you get frozen after 8-9 hours of surgery in a microscope, but it is very rewarding, as I would tell you. I mean, especially intraoperatively, you see that the color of the urine has become green, and you see that, okay, the limb has become soft. You feel very attractive.
Yeah, bilkul, sir. Totally agree with you. And sir, one last question from my side, and then I'll ask all my participants if they have any question in their mind, they can directly ask from you. Sir, from where did you receive this training? So, sir, there may be some other enthusiastic surgeons, plastic surgeons.
I will tell you. I attended some conferences where I saw the live surgeries and all that. And I belong to Patna. Okay. I have been traveling there once in a month for almost 15 years, still before COVID. I used to see patients. I mean, there's filariasis is very rampant over there. So it is just a small story that I said that I don't have any treatment for that. Except for non-surgical this thing. He said that patient went out. I overheard him telling, what this doctor is not good and all, he doesn't know anything. ऐसा थोड़ी होता है कि ट्रीटमेंट नहीं होता है, बॉम्बे में भी ट्रीटमेंट नहीं होगा, ये तो सवाल ही नहीं आता है. That forced me to do it, and then it was a learning experience overall. But, thankfully, no patients have failed. I mean, that is a real thanks to God.
We certainly, sir, medical community and the society also needs surgeons like you who are motivated and readily able to provide new and new innovative services to the society, because it requires a great deal of time during training period, then giving time. There is a learning curve, and in that time you get some failures. Others may judge you with your results. So a lot of motivation is required when you introduce some new concept, new surgical concept into the medical community.
Only one time I think I failed was when I did a nodovenous shunt for a filariasis patient. A lot of people especially down south are doing. And I did a nodovenous shunt and it failed after that. Lymphaticovenous shunt has never failed. And I think nodovenous shunt fails because we do not address the fibrosis. Okay. So afferent vessels fibrosis, which is not in the case of breast cancer and all that. But that is where, but each surgery has to take with a pinch of salt any failure. But yes, that is the only time.
Every case is a learning case for us. We cannot claim that now we are expert and
not at all.
Till the time we are alive and we are practicing, we learn from each and every case. And with this, I would like to request all the participants, the forum is now open for discussion. So if they have any question in their mind, they can directly ask Dr. Anshuman Manasvi, sir. He is all there with you to answer your questions. Sandeep sir would like to add some comment to the discussion. Can share your experience as well. You did your training from Jhansi. Jhansi is a endemic area for filariasis.
Can we take away this photograph from the screen?
Sure, sir. Yeah, now I am stopping this screen share. Yeah, fine. Thank you, sir. So filariasis is very endemic in Jhansi. I often see so many of my relatives are also affected with it. So as a plastic surgeon, would you like to add some comment to it, to what we have discussed till now? You are muted. You are muted, sir. You can unmute yourself. Hello. Yes, sir. Yes, Sandeep Kansal, sir. I think there is some problem with your audio. Yeah. So I have some patients with me. I'm really thinking seriously to ask them to consult you at least once, maybe online, if you have this facility, so that they can have a consultation. If they find any feasibility.
We have online facility.
Yeah.
There is no problem.
So I may ask them to consult you in case they find everything feasible and something. So I would also be glad to see the results, if any.
Yes.
Yeah.
Definitely.
Sir,
Yes,
may
Sandeep?
I ask you a question?
Yes,
I'm Dr.
sure.
Mukta Bakshi.
Yes,
Okay.
Mukta ji. Tell me.
Sir, I just want to know that for how long will you advise conservative treatment to any of the lymphedema patients and then switch over to the surgical treatment?
Okay.
Because initially, as you said, many people will not get ready for the surgery, especially for this kind. And maybe for some time, we can give them a conservative management to see if it responds to that or not. So for how long you feel we should advise them to go for conservative, and if it is not responding or it is poorly responding, then maybe go for surgery?
Okay. That's a very tricky question, but I would want to answer it in a different way. Yeah, I have given you the protocol which is being followed by one of the best centers in the world, and that is in Taiwan. And still, I would want to make it more of a evidence-based rather than being clinically oriented, or rather than leaving it to the patient. If we really want to help the patient, we have to tell the patient that you are there in the first 10% where there's a difference. Be aggressive in your conservative management if you want to avoid a surgery. And make sure that the patient is monitored for limb change, girth change. And if it remains between 10 to 15%, continue with it. But if it is more than 15%, you tell them clearly that it is unlikely to reverse, is likely to go back, because sooner or later you will have lymphangitis. So there is a very high possibility that you may land up with a grade 3 or grade 4 lymphedema. Nobody lands immediately in grade 3 or grade 4. It always is gradual. Lymphangitis is the most important precipitating factor. So try and convince them. If they are convinced, fair enough. If they are not, I mean, it is their choice. How long we should be convincing them, it is between the patient and the doctor. You cannot keep on telling the patient, unless otherwise the patient will start thinking that there is a vested interest. So you have to keep your clarity, take consent that you have told this patient to undergo this surgery. Now, medical legal problems are very common now. Take a consent that you have advised this patient a lymphatic surgery for lymphedema based on these factors. Grade diameter is circumference is more than 15%, 20%, and then tell the patient clearly that he has been explained, and let the patient decide later. You can show the results. You can show the results that these are how patients will become benefit. If not, you can land up somewhere else. That is how I would go.
Yeah. What's the experience with lymphapress and all?
Yeah, lymphapress is good, provided it is the pressures are advised by somebody who has been using it. And as I told you, in a limb which has not undergone a change, from 60 to 80 mm mercury is good enough. But if there are changes, it may go on to 100, 120. So how much pressure the patient is able to tolerate without much of pain is my way of looking at it as to how much the pressure should be given. There are no fixed rules. Guidelines say, 120 to 180, but where between 120 to 180, which patient will land is only when you will start doing it repeatedly. And the pain point is something which I think is a good this thing, that the enough pressure is being transmitted down. Because if the skin is thick, you may give in 160 and still the pressure may not reaching at the lymphatic level, maybe only around 70, because the thick skin may be absorbing all the pressure. So pain threshold is something what the patient can tolerate, is what is the guiding factor. Lymphapress is good. Initially, I was skeptical about it. Now I have started using it, but I show and I try to put it in a different modes. We can have one more this thing on how to set the lymphapress machine. We can have a separate discussion on that. So I try to mimic it with the manual lymphatic drainage. So I'm looking at advanced machines which can mimic all the 4 steps. I'm working on it so that just a single movement from distal to proximal sequential, say thoda sa it is better.
And just one more question, please.
Yes.
Any experience with Ayurvedic preparations, like, because they are sometimes very good in displacing the displaceable fluids?
Yes, so especially in Kerala and all, there are good centers giving very good result with Ayurvedic massage. In fact, I'm planning to send my team over there to learn some things over there from them. And they are doing a wonderful job. Let us be very, very clear about it. So it will be a great learning experience. I don't have personal experience. But yes, it will be, they are doing a good job.
Thank you. Thank you, sir.
Thank you very much, Mukta ma'am. You asked very, very valid question, and about this Kerala Massage Center, we'll ask from you and Anshuman sir. Maybe if you can share here some of our colleagues, they may wish to send their patient to that center to have some experience about. Maybe that will be a bit cheaper for them as well.
So I think I don't know how to go about it. It went off my mind, but we're planning to send our therapists over there to learn how they do it.
I think, sir, we should have one such therapist in the team, so that it is a complementary to whatever you are doing as a team, and maybe you can add on some persons like that, because ultimately when you are doing the surgery, after that also to keep it like that, to maintain it, you can use that Ayurvedic things also to maintain the your results. So that can add to it.
So only thing is, I don't know whether it is the Ayurvedic oil which is making the difference, or it is the technique which is making the difference. I think it is the technique which is making the difference.
But sir, they are medicated oils. So I think we have to do some research on that. We can't really say that.
No, I mean, medicated oil will also not do any harm. So, but it is difficult to, not all Kerala Ayurvedic centers are able to replicate that result.
Right.
And let us be very, very clear on that. Only 1 or 2 centers are giving that good result. So, I mean, they also must be having their own tricks of tricks of the trade, which they may not be wanting to share.
Yes.
Certainly, sir, certainly.
Sure.
One very important question is asked by Dr. Preeti Harmath, and she's asking, will use of lymphedema pump before surgery help us to assess the extent of fibrosis and hence the outcome of surgery? Like, can with lymphedema forceful pump, like graded pumping, we can assess that this particular patient will be more benefited with surgery. This patient has more displaceable fluid. Otherwise fibrosis हो गई तो आप क्या फायदा उसको करने का? तो ऐसा भी कुछ है क्या?
तो इसमें 2 चीज है. I will tell you. I mean, this is a important and point is valid. But one important thing which we have seen, and which we have seen very regularly, is that when you are actually there, I mean, you can imagine there is a lot of pipes, small pipes which are there, and into which are fibrosed in bundles. And when we are dissecting for 4 hours, we are literally separating each pipes, each lymphatic channel. Okay. So what it does, the surgery, it releases the lymphatic channels from their adhesions. So lymphatics, even if they were blocked because of pressure from outside, they open up. That is a really good insight which I have, that those patients whom we thought will not improved, because the flow of the lymphatics started because of the release of the fibrosis. So unless and until those fibrostic bands were released, lymphatic flow will not obstruct. So I may not be very true that what is displaceable before the surgery will remain displaceable. Only that much will be remain displaceable after the surgery. So during the surgery, a lot of lymphatic channels become free. They are able to breathe. They are able to flow much better because of the release of the mechanical obstruction.
What I understand from this jitna bhi I'm extremely sorry, my audio went off in between, so I was not able to listen much. So sir, what if I can understand कि जब हम pre-operative, like suppose we are planning for a surgery in any patient who is highly motivated and we do some lymphedema pumping, so with this agar wo fibrostic bands they get released and like suppose there is a decrease in edema, so we can expect कि इस patient को ज़्यादा फायदा होगा, something like this.
No. So what I'm telling something different. I'm telling even if there is not much of improvement with the massage pre-operatively, you can still expect good relief, because intraoperatively, when we are dissecting all the lymphatic channels from each other, we are releasing the mechanical pressure with the fibrosis is putting on the lymphatics, which become occluded because of external pressure on the lymphatics. Once they are released, the lymphatics is able to flow. So that is no reason why a patient should not be offered a lymphatic surgery. So, and this I have repeatedly seen that the lymphatic release is probably one of the greatest factor why the edema decreases after the surgery. This is one important takeaway. Uh, I think I showed it one of my slides. That
Yes sir, and I think we are done with all our questions. Is there anyone
थैंक यू सर, आपने बहुत अच्छी. अब सुधी के डॉक्टर सुधी के साथ हम lymphovenous stent भी स्टार्ट करेंगे and we will call you if we face any problem.
thank you so much.
सर बिल्कुल हाँ, आई एम रियली वेरी delighted to share that I had a wonderful evening with wonderful people like you. Sir, I learned a lot in today's program. Many new things I did not know much about. I only heard about them in somewhere in literature, but in today's session we saw those images, actual images, with the surgeon who is actually doing the cases, with the results, and those are really promising because we understand these patients are really distressed, though they may not show, but their quality of life, their other psychosocial issues, they are always there with them. So possibly it is a promising therapy for them. If no results we are getting with the conservative management, certainly this is something we must think about. Cost is always a constraint, we understand. So maybe now that so many plastic surgeons in our forum, so many breast surgeons in our forum, they know about this, they will try at their level best to introduce this concept in their area, maybe in a small bit right now, but certainly gradually they'll try to introduce more. With more and more results, we will be more and more confident about this therapy. And I'm very thankful to Dr. Anshuman sir for giving his precious time. Today is his son's birthday, a very important day for him, but still he took out time to tell something which is very new to us and very informative, very informative and very important for our patients as a breast surgeon. I am very thankful to Dr. Sandeep Kansal sir to take out his precious time and to moderate the session. And I hope he along with all our other participants must have learned something new. Friends, before finally closing the session, for all those who do endocrine surgery, please be ready for our upcoming session in May. In that session, we will be showing the scarless thyroidectomy that we are now doing routinely. And this is also something very, very new and innovative technique that is being done in it is now readily available and we are routinely doing. So we will take the opportunity of the endocrine meet in May to demonstrate how actually we do the scarless thyroidectomy and what are the pre and the post-operative results, especially the post-operative patient's feedback. So please gear up. I'm excited to attend the meeting, to conduct the meeting. And with this, I thank you all. Friends, those who have missed the meeting or in due to some reason, as a protocol, we upload all our meetings on YouTube channel. After this meeting, we will share the link to you all in couple of days, and we will share the link from where you can access all our previous other meetings also. So please don't get disheartened if you miss any of our meetings, and certainly you will appreciate. We feel good if you add some comments or share or subscribe to our channel. It will motivate me and my team. So, sir, please share your experience about, and then we will stop. We will just leave this meeting. Anyone, anything want to share with us? Okay, Anshuman sir.
I mean, it was my pleasure, and I thoroughly enjoyed it. I was engrossed because this is something which is very close to my heart, and I'm happy that I was of some help in imparting some knowledge about this subject. And thank you for giving me this opportunity to be a part of this wonderful team. Thank you so
Thank you,
much.
sir. Thank you. Okay, sir, now I am closing this meeting. I thanks once again to each one of you for being a part of this. Thank you.
Thank you.
See you next time in May. Bye.
Bye.